Good afternoon, everyone. My name is Joshua Berry, and I am the Health Promotion and Disease Prevention Analyst at ASTHO, the Association of State and Territorial Health Officials. I am honored to welcome you to this webinar on behalf of the Tobacco Control Network, and I'm honored to be joined today by Barry Sharp, Chair of the TCN Executive Committee and Manager of the Tobacco Prevention and Control Branch within the Texas Department of State Health Services. We are looking forward to the rich information being shared today and your questions on today's webinar, Examining Education Disparities in Tobacco Use. Before we get started, I'd like to overview the logistics for this afternoon's webinar. You will have the option of listening to this webinar through your computer speakers, which is the preferred method, or over the phone through the toll-free number and passcode shown on your screen, but please do not use both methods to avoid audio feedback. This webinar is currently being recorded, and a link to the recording and the webinar slides will be sent to you via email soon after the recording is available. The recording and webinar slides will also be posted on the ASTHO and TCN websites in approximately 2 weeks. We invite you to participate in this afternoon's question and answer session by typing your questions into the on-screen chat box at any time during the webinar. Computer and phone lines will be muted for the duration of the webinar, so please plan to use the chat box. As you can see, we have a full agenda to cover this hour, and we also have a number of meeting objectives. And our goals on this webinar are to define terms related to health equity and health disparities, and explore their connection to tobacco use and tobacco-related disease in the United States. We also hope to discuss how to connect with non-traditional partners in an effort to promote tobacco control in the priority populations we'll be discussing today. And also, our goal is to present case studies of successful collaborations that have helped improve health outcomes for individuals with lower educational attainment. So quickly, a little bit about ASTHO. ASTHO is the national nonprofit organization representing public health agencies in the United States, the U.S. territories, and the District of Columbia, and over 100,000 public health professionals that these agencies employ. And now to introduce the Tobacco Control Network, I would like to give the floor to Barry Sharp. Barry?
Thanks, Josh. The Tobacco Control Network, or TCN, is an ASTHO peer group and is comprised of tobacco control program managers and additional tobacco control programs such as the Funders Alliance, and additional staff from each state, territory, and the District of Columbia. The partnership between ASTHO and TCN provides a very valuable linkage to tobacco control programs across the nation and assists ASTHO in achieving the goals of tobacco prevention and control with an accurate state-level perspective. Next slide, please. The TCN Executive Committee includes a diverse representation of state-level tobacco control stakeholders from across the United States and territories, from Rhode Island to Guam. This allows the Executive Committee to represent the TCN members working in tobacco control throughout the United States. Next slide, please. Now it's time to give the floor to the two speakers joining us today. Presenting first is Yolanda Savage-Narva. Yolanda has devoted her professional career to helping people live their best and most healthy lives. She currently works with ASTHO as the Director of Health Equity, where she is responsible for promoting health equity both internally and externally. She has a Bachelor of Arts degree in Sociology with a certification in Gerontology and a Master of Science degree in Education. Yolanda, thank you for joining us.
Thanks for that great introduction, Barry, and good afternoon, everyone. It is indeed a pleasure to spend this afternoon with you to take a look at how intersectionality and social determinants of health affect how we provide information and education around tobacco use and address health disparities. So before I start, I do want to pose a few questions to you all as I walk through my presentation. The first question is, why do more than 80% of the world's tobacco-related deaths and chronic diseases occur in low and middle income countries? Secondly, why are tobacco's harmful effects concentrated among groups who are most vulnerable? And thirdly, why is tobacco use still the leading cause of death in the U.S. and globally? This should be a global crisis. I just want you to think about this as I go through my presentation today. I want to share this slide with you. I want to start here. I think this pretty much says it all. In this caption, everyone gets the same amount of food, no matter what your size is, no matter how long it's been since you've had a meal, etc. So we really have to move away from this thinking and allowing it to dictate our actions when we think about eliminating disparities. So today, I want to just tell you a little bit about ASTHO, the 2016 President's Challenge, and what's the difference. I want to talk to you a little bit about some terms that we use to describe health equity and that we interchange often. Some real-life experiences of people who are dealing with tobacco cessation and tobacco abuse, and also other areas that cause concern, and then efforts to advance health equity and optimal health for all. So briefly, ASTHO's vision is healthy people thriving in a nation free of preventable illness and injury. And ASTHO's mission is to transform public health within states and territories to help members dramatically improve health and wellness. This vision and mission statement is broad in nature, but it also explicitly talks about the desire and goal of having a nation free of preventable illness and injury and transforming public health. Next, quickly, this is the ASTHO 2016-2018 strategic map, and this is just a screenshot. This map actually operationalizes the vision and mission statement of the organization by making health equity, that top section that says improve health equity and population health outcomes through transformational leadership, the overarching theme of programs and activities that ASTHO will focus on for the next 2 years. I hope this illustrates the commitment of the organization to integrate advancing health equity into everything we do. So the 2016 President's Challenge is on advancing health equity and optimal health for all. The President's Challenge started in 2009, and it's basically an opportunity for ASTHO's board president to select an area that he or she is passionate about and challenge his peers, or his or her peers, to walk the talk and also participate in this activity. This year's President's Challenge is issued by Ed Ellinger, Commissioner of the Minnesota Department of Health Equity, thinking about health equity, and he developed what we call our triple aim of health equity. And there are 3 pillars in this triple aim: expand our understanding of what creates health, implementing a health in all policies, and strengthening community capacity. A couple of examples for each of these. When you think about expanding your understanding, how do you develop educational materials for cross-sector partnerships? When you think about implementing a health in all policy with health equity as the end goal, how do you incorporate this into a bill or a funding announcement to make sure people do this activity? And then thirdly, strengthening the community capacity. Maybe developing a community engagement plan for your agency or team. These are some general examples, and I'll talk a little bit more about these specific to tobacco cessation and education and disparities. So quick definitions of the terms. I want to talk a little bit about what public health is, the social determinants of health, health disparities, intersectionality, and health equity and social justice. So first, I'm sure everyone knows this definition. Public health is what we as a society do collectively to assure the conditions in which all people can be healthy. So in public health, what do we think about when we think about public health? Primary, secondary, and tertiary prevention. So when we think about that in terms of smoking cessation, when we think about primary prevention, we want to prevent smoking before it starts, and this often targets youth populations. When we think about secondary prevention, we want to, at a minimum, reduce the impact of disease or injury that could potentially occur as a result of the activity. And then third is tertiary prevention. We want cessation, but we want to manage more chronic lifelong conditions such as emphysema, which affects quite a few minority populations. So these are some examples of public health and tobacco cessation. So I'll let you take a few seconds just to read this slide. I think we want to keep in mind that our end goal here is equity. People talk about equality and equity, but we want to make sure we achieve equity. So the social determinants of health. These are the conditions and circumstances in which people are born, grow, live, work, and age. These circumstances are shaped by a set of forces beyond the control of the individual, like economics and the distribution of money, power, social policies, and politics at the global, national, state, and local level. Some examples. Sometimes the amount of education targeted to youth groups and high-risk groups vary and are very important to pay attention to when we're thinking about the impact of social determinants of health. Another example, when we think about employment and how employment actually affects people, stress, lack of employment, underemployment are all factors. Family and social supports play a huge role as well. If people around you smoke and that's your environment, you need to see a different path in order to break through from that. So what is a health disparity? Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, or environmental disadvantage. It's based on racial or ethnic groups, religion, socioeconomic status, gender, age, mental health, cognitive, sensory, or physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion. Here's some facts to understand about disparities. African American men have higher death rates for lung cancer than white men. American Indian and Alaska Native populations have the highest rate of smoking in the United States. And 25% of U.S. adults who categorize themselves as multiracial currently smoke. This is the greatest percentage of current smokers than any other racial or ethnic category. And so these are examples of health disparities as it relates to tobacco use. Intersectionality. I don't know, this is a new term, and people don't think about how this affects addressing health disparities in communities, but it's very important. Intersectionality is the study of overlapping or intersecting social identities and related systems of oppression, domination, or discrimination. We will explore examples of how intersectionality affects people who use tobacco with our real-life story section in a moment. As you can tell, I like these pictures, but I think a picture is worth 1,000 words. So if you look at this, the teacher, I'm assuming, is shoveling the snow from the stairs. And there's a young person in a wheelchair asking, could you please shovel the ramp? And the teacher says, but I'm busy shoveling the stairs and I'll get to the ramp later. And the person in the wheelchair says, hey, if you shovel the ramp, guess what? We all can use it. So it's just something to think about when we're addressing equity. So what is health equity? Health equity, defined by Healthy People 2020, is the attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally. And I want to mention social justice because I know we talk about those terms very separately, but they're very integrated and linked. Social justice is the equitable distribution of social, economic, and political resources, opportunities, and responsibilities, and their consequences. So let's talk a little bit about intersectionality. I want to give you an example that actually, yes, I do have disabilities up there, about disabilities. So about 37 million U.S. adults have a disability, meaning that they have serious problems with walking or climbing stairs, hearing, seeing, or concentrating, remembering, or making decisions. So in this population, adults with disabilities are more likely to smoke cigarettes than those without disabilities. about 16.8% of U.S. adults were current cigarette smokers in 2014. So that's an example of what we talk about when we're talking about intersectionality. So at this time, I would like to give you some real-life stories about people who have dealt with this and dealt with intersectionality. Nathan, Native American, has actually never smoked cigarettes. For 11 years, he worked at a casino that allowed smoking. Secondhand smoke contains dangerous chemicals, and the exposure to secondhand smoke caused him to develop allergies and serious infections that triggered asthma attacks, eventually causing permanent lung damage called bronchiectasis. The casino was filled with smoke from so many people smoking. Breathing in other people's smoke on a daily basis made his health so bad that he had to leave this job. Nathan used to be active and athletic. He served in the Marines. He loved to participate in tribal dances. After getting sick, dancing just a few steps wore him out. Nathan hoped that sharing his story would help others understand how dangerous exposure to secondhand smoke really is. What's the intersectionality piece here? Nathan was exposed to secondhand smoke, but why? He's a member of a minority group, and we go back to the social determinants of health, and it talks about employment. He didn't really have a choice about where he was employed. So this is an oppressive policy, being in a place where he can't really help being. That's part of how he makes his living. But he was exposed to secondhand smoke, and unfortunately, it led to Nathan's death in 2013. This is a real-life story. I'm getting close to time. That's one story. I think I'm going to move to slide 19, past these two. Yes. So just a reminder, for a fair selection, everybody has to take the same exam. Please climb that tree. So if you look at this, can everyone climb that tree? I think we have to get away from this kind of thinking and approach to how we address equity issues. Everyone cannot climb the tree. We have to be very careful and cognizant that we meet people where they are and provide them with what they need at the time in their lives. So a couple of interventions and programs that have been very helpful. I don't want to sound like there's nothing going on to address intersectionality issues and health disparities, because there definitely are interventions out there. These interventions address individuals with multiple oppressions. So the Veterans, Place, and Race, the U.S. Department of Veteran Affairs developed a program that addresses veterans who are also working on tobacco cessation. And this program looks at veterans and the things that they need to get through this. One of the things is that they need constant support. They really need a support system to kick the habit of smoking and be healthy. And so, number two, if you're around a veteran, if you're smoking, quitting helps them too, because they really enjoy an atmosphere that's not around smoking and pushes them to do that. Encourage succession. Developing a smoke-free environment is very important. And then the Centers for Disease Control has also developed specific e-cards for vets that you can download and give to them that encourages them to continue to not smoke. An intervention from LGBTQ communities. So there is a program that is much more likely to help LGBT communities not smoke. The National LGBTQ Community Control Network has developed quit tips. And so here are some tips that have been given to folks to help them stop smoking. So Millicent said, when I was a new ex-smoker, I usually chewed gum or talked to friends and told them to never give me a smoke no matter how much I begged, and that usually worked. So that's a real-life tip. Another one from Perry. I've been thinking about quitting smoking, but I wasn't serious about it. Then I got word that my dad had died of a massive heart attack. his 2 packs per day, 40-plus year cigarette consumption was the likely cause. I felt so helpless that my mind searched for something to do about it. Of course, there wasn't anything I could do about his dying, but I could honor his memory by quitting the habit that helped end his life so early, and I haven't smoked a cigarette since I got that news. So there are interventions and programs that are targeted to multiple communities. So I really want to talk about a multi-sector village, how we achieve health equity together, a world free of tobacco and related illnesses and death. We have to look at historical trauma and the environmental influence on behavior. We have to look at all of the partners and stakeholders that are out there that can help us achieve health equity around tobacco. Access to healthy food, fair criminal justice system, affordable transportation options. These may seem like very different interventions, but at the end of the day, they all work together to achieve health equity. So I want to share this last slide with you about equality versus equity. So the right-hand side, this is what we want to achieve. This is the work that we have to do to get there. Now, it may involve removing some resources from one place to give to others, but true equity can only be achieved if we, the privileged, sacrifice and do our part in leveling the playing field. And keep this in mind, injustice anywhere is a threat to justice everywhere. Thank you for the opportunity, and I'll turn it back over to Barry or Josh.
Thank you, Yolanda, for a wonderful presentation. Presenting next is Dwana Calhoun. Dwana is the Director of Self-Made Health Network, a national network that specifically focuses on vulnerable, underserved, and low-resource populations with low socioeconomic status, characteristics residing in rural, urban, and frontier regions. Dwana possesses a Bachelor of Science from the University of Louisiana Lafayette and holds a Master of Science degree in Community Health from Old Dominion University in Norfolk, Virginia. Dwana has worked closely with diverse entities, including primary healthcare associations, healthcare quality improvement organizations, academic institutions, and hospital associations. Dwana, the floor is yours.
Thanks, Barry, for that introduction, and thanks, everyone, for joining us. And so we hope that you find the information presented on the topic potential opportunities to address tobacco-related disparities among vulnerable populations by level of education are not only beneficial to your state, but to the counties, communities, as well as patients and clients that you serve and value. So we want to spend the next few slides with providing you with just a brief overview about Self-Made Health Network. As one of the newer CDC disparity-focused networks, we strive to not only impact the health, but also the livelihood of vulnerable populations throughout the country with lower socioeconomic status characteristics. So that also includes residents of medically underserved areas and health professional shortage areas, the under and uninsured populations, as well as populations with lower levels of education and low-income employees. That includes not only full-time employees, but part-time, seasonal, contractual employees, and the self-employed as well. The Self-Made Health Network philosophy originates from a basic self-made concept that in the presence of affordable, supportive, and resource-friendly, not only environment, but also sustainable infrastructure that are coupled with resources, decisions among vulnerable populations will be consistently applied throughout the entire continuum of health. So although this concept has been modernized, it's based on the historical perspective that a man, woman, or child, as well as a teenager, can indeed become the captain of his or her destiny as it relates to health. So based on the understanding that the improvement of health outcomes is indeed a process, we at Self-Made Health Network strive to continue evolving over the next few years as we envision a nation where valuable members of society are considered the vulnerable, the underserved, and low-resource populations and that they would indeed routinely utilize services leading to not only greater opportunities as it relates to cancer-free living, but also tobacco-free environments as well. And so Self-Made Health Network was established in the last year and a half. And last year we were able to establish our first advisory council, and that's comprised of 15 member organizations that vary from the Catholic Health Association of the United States to the National Health Care for the Homeless Council. We also have a couple of academic institutions on board as well, including the Center for Tobacco Research and Intervention with the University of Wisconsin School of Medicine and Public Health. We also have on board with our organization, the American Healthcare Quality Association, with a complete list of our member organizations that are part of the advisory council are listed on our website. So despite significant progress since the first Surgeon General report that was issued 50 years ago, smoking continues to remain the largest cause of preventable disease, disability, and death throughout the United States. And the estimated economic cost attributable to smoking and exposure to tobacco smoke continues to increase and is now approaching approximately $300 billion annually. And this includes medical costs accounting for $130 billion annually. And what's so important as well is that throughout the United States, approximately 16 million Americans are living with smoking-related diseases. So shown above is just one example of significant findings about women and smoking from a historical perspective. So the once-wide gender gap in smoking prevalence narrowed into the mid-1980s and has since remained fairly constant. The smoking prevalence increased to nearly 3 times higher among women with 9 to 11 years of education compared to women with 16 or more years of education. But what's so significant about this report as well is that it also noted that girls who initiated smoking were more likely to also have parents or friends who smoke. They were also reported to have weaker attachments to parents and family, stronger attachments to peers and friends. They also perceive smoking prevalence to be a little bit higher than it actually is, and are inclined to be risk takers and rebellious. But what's also noted in the report is that females also reported to have a weaker commitment to school and lower levels of education. But although the strength of association by gender differs across studies, most of these factors that are associated with smoking or increased risk for smoking correspond to both girls and boys. So how can we decline smoking among men and women who are less educated to accelerate this decline? Sorry about that. So perhaps one answer to this question lies in addressing several socioeconomic status factors that are associated with smoking, but not only smoking, but tobacco use in general. So socioeconomic status, I'm not going to go into too much detail. Yolanda did a great job in providing a nice general definition, but we wanted to ensure that you all were aware that socioeconomic status is not only measured by a couple of the indicators that are noted on this slide, but these indicators can also have different types of influences on health behavior. Lower socioeconomic status is also associated with higher mortality rates, and the greatest disparities occur in middle adulthood between the ages of 45 to 65. And it also includes populations that are usually deprived not only economically, but that live in disadvantaged neighborhoods or work sites, and they may face a variety of chronic stressors in daily living. So they may struggle to not only meet their basic survival needs, but they may have or experience fewer opportunities to achieve lifetime goals. They may experience more negative events, life events such as unemployment, marital disruption, and financial loss. And finally, they may have more episodes of experiences with discrimination, isolation, and powerlessness. So these stressors can potentially trigger a host of compulsive behaviors, but they can also be exacerbated when these populations also possess lower levels of education. The disparities is also associated with tobacco-related burden, secondhand smoke exposure, and of course, tobacco initiation behaviors among adults. And these disparities exist not only by income level and industry type, but by other relevant characteristics. And in the United States, persons or populations living below the poverty level, as well as populations with lower levels of educational attainment, also have reported higher levels of cigarette smoking. So, for example, populations with the highest level of education being defined as a GED certificate, their smoking prevalence is more than 40%, which is the highest among any socioeconomic status group. So as a result, for purposes of today's presentation, our primary focus will include lower levels of educational attainment. So according to the United States Public Health Service's clinical practice guidelines, individuals with not only lower socioeconomic status characteristics, which really include individuals with lower levels of education, they bear a disproportionate burden from tobacco use, which ranges from a higher smoking rate to a number of other variables or circumstances that are factors that are listed here. But lastly, if you look at the last bullet, they experience greater exposure to more permissive environmental and workplace smoking policies. And populations that reside in these groups also experience lung cancer risk that is higher compared to other groups, and populations with less than a high school education also are diagnosed with lung cancer at higher rates compared to those with a college education. So tobacco-related disparities exist by levels of education, and poverty levels are shown on this slide, and then we'll go a little deeper in the next slide. But for example, populations with a high school education that smoke cigarettes for a duration of more than twice as many years compared to populations with at least a bachelor's degree places them at higher risk for not only becoming addicted and being categorized as heavier smokers, but also places them at higher risk for lung cancer and other conditions attributed to tobacco use. And in addition, populations that are living in poverty who smoke cigarettes, they usually smoke cigarettes for a duration that's nearly twice as many years compared to a population with a family income of 3 times that poverty level. In addition, when we examine the smoking cessation rates in general, populations with a high school education of 9 to 12 years but no high school diploma experience less success in quitting, a rate of 43.5% compared to those with a college education or greater, at a rate of 73.9%. And in addition, when we look at other factors such as by industry, among vulnerable populations, the highest smoking prevalence is among workers in accommodation and food services, followed by workers in the construction and mining industries. And what's so important as well is, as you scroll down to the bottom of this slide, secondhand smoke exposure remains highest among populations living below the federal poverty level, as well as populations with less education, which in some circumstances these factors overlap. Behaviors historically associated with smoking are associated with low income and a cluster of social contextual factors, including unemployment, lack of social support, living in unsafe neighborhoods, as well as having unmet needs for food as well as medical care. And as we briefly examine other tobacco products as it relates to vulnerable populations as well as populations with a college education, the most recent CDC report findings indicate that in addition to cigarettes, current use of not only cigars but smokeless tobacco products remain highest among populations with less than a high school education. The perceptions of smoking and class distinction continue to remain as important factors associated with vulnerable populations. So, for example, in some instances, smoking is stigmatized more among the highly educated populations than the less educated populations. Class distinction sometimes gives motives for higher socioeconomic status populations to act in what we call healthier ways. And it also creates the potential to motivate lower socioeconomic status populations or groups to set themselves apart from higher socioeconomic status populations. And so this is so important because it's really important to understand sometimes the thought processes that affect the decisions that are made by vulnerable populations, including those with lower socioeconomic, including those with lower levels of education. And with that being said, sometimes smoking may be perceived in some contexts to symbolize independence or toughness or freedom from convention. Despite the complexities that are associated with tobacco use, the good news is that if we can find a way to assist even more populations, including those with lower levels of education attainment over the next 50 years, the results could be staggering. So, for example, 1 out of 3 cancer deaths associated with tobacco use in the United States could be prevented. So this may correlate to less communities losing their favorite teachers or principals or coaches or bus drivers or custodians. Less families would lose their grandparents or their parents to a tobacco-related cancer. Less employers would lose maybe would not continue to lose their favorite hardworking employees to a tobacco-related condition as well. And finally, less physicians would lose their patients to tobacco-related cancers. So as noted in the Institute of Medicine's book, Ending the Tobacco Problem, A Blueprint for the Nation, there's a phrase in there that's so compelling and resonates with our current era as well. And it says that achieving success in substantially reducing tobacco use will require taking stock of the progress made with current tobacco prevention and control strategies and identifying where potential opportunities exist in response to emerging trends associated with tobacco use and the characteristics of behaviors of subpopulations of tobacco users with particular vulnerabilities. So as we think about social determinants of health being defined as conditions in which all people are born, grow, live, and work, as well as age, we hope that by the end of today's presentation, you also think about that definition so that it kind of correlates a little bit more to vulnerable populations. So, for instance, it could be paraphrased to say conditions in which the less educated populations born, grow, live, work, and age. And this is so important because vital factors such as poverty, housing, social support, healthcare access, education, transportation, as well as discrimination are all vital factors that influence tobacco-related disparities or contribute to tobacco-related disparities. So one potential solution to kind of turning the tide as it relates to tobacco-related disparities may include inviting the right partners to the table for greater reach, depth, and sustainability within vulnerable communities. So the next few slides are just intended to provide just a general an abbreviated overview of potential opportunities to address tobacco-related disparities as it relates to, for instance, partnerships. So in addition to creating a culture of mutual trust, respect, commitment, and inclusivity, it may also be helpful to create mutually beneficial relationships where you're seeking to understand diversity in perspectives, personalities, experiences, expertise, and maybe unfamiliar or non-traditional approaches. In addition, it may be helpful to also maintain not only an ongoing awareness of factors that may prevent interest or receptivity from an organization at a particular point of time, but also consider other important factors as you think about developing mutually beneficial relationships with non-traditional partners, such as being receptive to learning how a potential partner defines a successful, effective, and sustainable partnership. And finally, seeking and exploring different ways that partners may define themselves as the best fit for not only your mission, but their organizational mission as well. And lastly, always plan for sequential and small milestones toward achieving larger goals. In addition, as noted in one of the CDC Guide's best practices user guides on health equity and tobacco prevention and control, it may be helpful to not only invite new members from non-traditional organizations to the table at the end of the process, but it's so beneficial to invite them to the table at the beginning of either your planning process or when you're reviewing data, and to also ask them to provide you with input about key findings and assist with how the data or the results should be shared, how the messaging should be developed, as well as what are the most appropriate mechanisms for disseminating the information so that it resonates not only with your targeted population, but organizations that provide services to populations with lower socioeconomic status characteristics, including those with lower levels of education. And that will not only contribute to the community's commitment to efforts, but it also allows the community or those organizations and the populations to be a part of the solution and to have some type of ownership as part of their identity as a community.
Hi, Dee. This is Josh from ASTHO. Real quick, I want to remind everybody to please use the chat box to submit questions to both Dee and Yolanda for our Q&A session. And then, Dee, we hope to get that Q&A session started in the next couple minutes. So if you could take us through the rest of your presentation, that would be wonderful.
Oh, great. Okay, we surely can. And so the good news is as well, these slides will be available, I think. So if I'm not able to get through the last 4 slides, please feel free to review them at your own, in your own leisure time. And so this next slide is just a general synopsis about surveillance and an example of how you can optimize your surveillance efforts to work with organizations that service populations with lower levels of education. So this is, what we did is I just used an example from one of the CDC's guides, the key outcome indicators for evaluating comprehensive tobacco control programs guide. And so, for instance, if you are focusing on reducing the initiation of tobacco use among young people, for example, you may want to focus on 1 or 2 of these indicators in the context of focusing on your organizations that work with disadvantaged youth, or you may want to consider working with juvenile detention centers or organizations that provide health care or non-medical services to homeless or transiently housed youth. And so this next slide just shows just a general depiction from a report by the Institute of Medicine on growing up tobacco-free, preventing tobacco addiction in children and youth. And this is so important because if smoking rates continue at the current rate, 5.6 million up-to-date Americans younger than 18 will die from premature illnesses associated with smoking. And so it also features not only stages of addiction that can be addressed in youth and children, pediatric populations, but also populations with lower levels of education as well. Okay, and then so this slide and then the last slide, I've just feature a few more examples of windows of opportunity. So, for example, you may want to consider increasing the amount of tobacco-free policies within middle schools or high schools with a detention or dropout prevention program. You may want to consider partnering with and or funding and providing technical assistance to these types of organizations. Another example is just a policy-related example where you may want to increase the number of tobacco-free or smoke-free campuses that include a juvenile detention center. Or lastly, you may want to consider partnering with, for instance, a national local bus line such as Greyhound Bus, so that you can reach not only lower educated teenagers but adults and families as well. And then you may want to consider utilizing your data to see if an impact has been made. So in conclusion, this field is ever evolving, yet it provides us with an opportunity to reduce a lot of challenges associated with tobacco use among populations with lower levels of educational attainment. And we at Self-Made Health Network, we're currently looking forward to releasing a series of guidance documents beginning in the early fall to further assist states and their partners and other types of organizations with addressing this important issue. And displayed above is just a snapshot of our website, and we're happy to announce that it not only contains access to webcasts, but our first set of fact sheets have also been released and are featured on the website. And that's it. Thanks again for taking time to learn a little bit more about populations with lower levels of educational attainment.
Thank you, Dwana, for your presentation, and thanks again to Yolanda for joining us this afternoon as well. It is now time for the question and answer portion of today's webinar, so I'll turn things back over to Josh.
Yeah, thank you so much, Barry, and thanks again to Dwana and Yolanda for joining us. So we have time today for questions and answers, so I'll be moderating the Q&A session, and I'll direct inquiries that you're sending in from the chat box to today's speakers. And just as a final reminder, phone and computer microphones will be muted for the duration of the webinar. So if you would like to ask a question, if you have a follow-up question or a clarifying question, please utilize the chat box as we address questions. So first, I'd like to start off with addressing a logistical question that we've been seeing a couple times. Yes, slides and a recording of this webinar will be made available to you via follow-up email, and then they'll be posted on the ASTHO and TCN website. So we hope to have those materials readily available for all of you if you'd like to consult this presentation in the future. Moving on, we do have a question for Yolanda. Yolanda, how can ASTHO's President's Challenge inform state-level tobacco control efforts that address disparities by educational attainment and other social factors?
Well, that's a great question, Josh. And actually, the triple aim of health equity, in my opinion, is a way to address control efforts that address disparities. I think the foundation of the triple aim, expanding our understanding of what creates health, implementing a health in all policies with health equity as the end goal, and then strengthening community capacity to create their own healthy futures is the kind of foundation we need to address state-level tobacco control efforts. Using those pillars to operationalize your activities. So, for example, expanding our understanding of what creates health. That triple aim pillar is really designed to help us think outside of the box and understand how, for example, transportation and public health can work together to address tobacco cessation and disparities. For example, transportation is vital for people who are trying to get to maybe meetings or to get to services that will help them continue their tobacco cessation activities. So if public health and transportation team up, there's an opportunity right there to work kind of across the aisle, so to speak, outside of non-traditional partnerships, and to focus on how the two sectors can eliminate health disparities. Another example is working with the housing community. Another example, of course, is working with environmental health and environmental justice partners to address this issue. So when we think about the second pillar in implementing a health in all policies approach, I think that's really important because We want to work with other sectors for them to understand the impact of what they do on health. I think that's another example. And then one of the most powerful for me is the community piece. How do we work with community partners, people who are actually in the community on a day-to-day basis to address some of the issues that we have around educational attainment and disparities?
Yeah, thank you so much, Yolanda, for that response, very detailed. And we have a question here for Dwana. Dwana, how can health departments go about reaching out to those non-traditional partners that you were discussing?
Well, sure. That's a great question. So there are a couple of options for state health departments. You may want to start with maybe conducting a partnership scan to begin with existing partners and ask your existing partners if they have a relationship with a certain non-traditional partner that you're interested in partnering with, or do they provide services to a particular population that you're interested in reaching. You can also consider conducting kind of a contract and a vendor scan as well, and ask your existing contractors or vendors the same questions. But it's also an opportunity to kind of learn more about kind of the potential organizational structure and culture, history, the gatekeepers, the interests of those organizations of interest. Sorry about that. But also state programs can also involve their partners who were part of the development of their strategic or their annual plan and ask those partners as well if they have an existing relationship with non-traditional partners of interest. And it's also helpful to kind of conduct your own research to learn more about those non-traditional partners, non-traditional organizations, what their mission is, their vision, what are their legislative priorities. Where do they provide services to populations? Who are the populations that they serve? Do they service one county or multiple counties? What type of partnerships do they have? And sometimes that information is listed on their website, or if you conduct an informal meeting with those partners as well, or those potential partners as well. And it's always nice and effective to also engage those partners based on a minimal introduction, so that you avoid assuming that they are knowledgeable about your organization's specific role as it relates to tobacco control. And it's also helpful to avoid assuming that tobacco efforts are indeed a priority for their organization.
Yeah, thank you so much, Dee. We do have another question coming in for Yolanda. Challenges occur, and for Dee, challenges occur state by state based in part on state money available for development of programming and resources. So what do you both recommend for states who are not able to dip into master settlement monies from tobacco settlements? Yolanda, would you like to start?
Yeah, I'll jump in, and Dee, I'll leave some time for you. I'm sure you have some perspective on this. One of the things I think that's very important is to make sure that the money that's already there, the existing funds, be protected and used explicitly for the reason that they were given, and that's around tobacco cessation and health disparities around education attainment. So I think that's one thing. I would also add quickly that this is an opportunity to branch out to other partners and get them to understand how assisting with tobacco cessation and education attainment around disparities helps them as well as the program. So this is an opportunity to reach out and kind of diversify that funding stream.
Do you have any thoughts on that as well?
Yes, I'll piggyback, Yolanda. We actually share kind of the same response. My first response is leveraging existing partnerships, and sometimes at the state level, I originate from the State Department. We have a tendency to kind of work primarily with state agencies, but this is a nice opportunity to kind of broaden that net and reach out to non-traditional partners, such as other non-profit organizations, community organizations. And sometimes you may be surprised and look up sometimes you don't need additional funds. You can leverage your expertise, and that organization may actually have additional funding if you have shared goals, and they'll be willing to commit to goals that you're actually interested in as well. But it also provides states with an opportunity to kind of prioritize. So you want to prioritize your make a priority list based on what organizations are actually interested in committing to the goals that you have kind of defined, which you want to allow for some type of flexibility as well. And also you're going to prioritize by capacity which of those non-traditional partners have the capacity to assist you with not only meeting your goals, but meeting their goals as well for their community, and also which organizations have either a greater reach or more in-depth reach to the population, such as your populations with lower socioeconomic status characteristics.
Yes, thank you, Dee. So we have time for one final question that we'll be able to direct to both our speakers. Someone is asking, during the presentation, was there a focus on industry profit as a primary vector being emphasized, thinking that perhaps the onus should not be put on just demographic factors other than the source of the products, the tobacco industry itself. So, Dee, do you have any thoughts on that?
I didn't. Bear, can you repeat the question? Or is that Josh? Can you repeat the question?
Sure. So this is Josh. So someone is wondering, they were asking, was there, during the presentations, was there any mention on industry profit as a primary vector, expressing that they're cautious about putting the onus on demographic factors as far as, I believe, describing disparities in tobacco use as opposed to the industry?
Yes, I didn't mention it in my presentation. Yolanda, did you have any additional information?
Well, I do understand that at times a retail density analysis as well as a community health assessment can be done to figure out the role that retailers play and how that influences like more affluent neighborhoods versus neighborhoods with lower socioeconomic statuses.
Yeah, thank you, Yolanda. Dee, anything to add really quickly before we finish up this afternoon?
I just have this one anecdotal thing. I think what we wanted to eventually move to as well is empowering vulnerable communities so that populations, even in the presence of tobacco products around the corner, down the street, they make a decision not to purchase the product, because the economic component is very important. And so if we're able to decrease demand for tobacco products, that may be a very significant factor that could lead to kind of a reduction in not only tobacco consumption and illnesses, but healthier communities nationwide.
Mm-hmm.
Oh, yeah, thank you, Dee. And so I see that we're approaching the end of the hour, so I'd like to thank everyone attending us for questions, and thank you again to Dee and Yolanda for providing responses, and I hope the Q&A was helpful in taking a deeper dive into the presentations. So I would like to remind everyone really quickly that to visit the redesigned TCN website and access the resources that the Tobacco Control Network has publicly available, which include submitting a Help Your Peers request to receive feedback from the full Tobacco Control Network, to view copies of the archived biweekly TCN newsletter, and you can also review a directory of all TCN members from throughout the U.S. states and territories. And again, the webinar slides and recording will be made available on the TCN website. And if you have any further questions, you can please direct those to the email shown there, tcn@astho.org. ASTHO.org. And again, if anyone here attending the webinar has any state success stories that they are able to share with ASTHO, we're still interviewing states to try to get a sense of what work is being done so we can share those state success stories with our extended audience. And if anyone has any state success stories they'd like to share, you can reach out to me directly at jberry, B as in boy, E-R-R-Y, at ASTHO.org. And then as we wrap up here momentarily, you will be directed to a Qualtrics survey, and a link to the survey will also be made available to you via email. So please take a couple minutes to provide feedback on this webinar through that survey, and it provides us with useful information for our further projects, our future projects, I'm sorry. And so this concludes today's webinar, and so I would like to take this opportunity to once again thank Yolanda Savage-Narva, Dwana Calhoun, and Barry Sharp for joining this afternoon. And I'd also like to thank everyone from ASTHO and the Tobacco Control Network who contributed to today's webinar. And then again, a recording of today's webinar will be sent to you via email, and it will also be posted on the TCN website in about 2 weeks. And if you have any inquiries about the TCN, again, please feel free to reach out to us at tcn@astho.org. So thank you, and enjoy the rest of your day.